is Dr. Jonathan Leffert. I'm a clinical endocrinologist in Dallas, Texas, and the current president of the American Association of Clinical Endocrinologists. I'm here today with Dr. Vivian Fonseca from Tulane Medical School. We're going to go over some cases to kind of put the whole process together of how to treat people with diabetes in relationship to insulin and other medications. So the first one is Maria. She's a 62-year-old Hispanic female with a 10-year history of type 2 diabetes. She started Glargine U300 6 months ago as an add-on to her orals. Her Glargine was titrated up, and her fasting sugars are in the 110 to 120 range. She currently has an A1C of 7.5%, which is not at goal. She works in a busy call center, she has a very light breakfast, and she snacks at lunch. She's very hungry at nighttime and eats her largest meal of the day at that time. Her medications currently are metformin, 1,000 milligrams BID, glimepiride, 4 milligrams in the morning, and Glargine U300, 34 units at bedtime. She is 156 pounds, is 5 foot 2 inches tall, has a BMI of 28.5. So Vivian, what do you think the options are for achieving her A1C goal?
So that, again, common scenario here. The lady's, she's trying a fairly new insulin. She's not on a huge dose of insulin, but she's not very obese. She's obviously titrated up to 34, and her fasting glucose is not bad. You'd have to titrate a fair bit more to get the A1C down to 7.5, and there's a risk of hypoglycemia there. You may want to discuss with her about her eating habits and spreading the meal through the day, not abiling weight gain as you get better. But clearly she's getting postprandial hypoglycemia. It's probably she's eating a very large meal when she comes home from work, and the blood sugars are high for several hours after that. It's surprisingly how long postprandial hypoglycemia can last when you have a large fatty meal. So one option would be to use a GLP-1 receptor agonist, particularly one that addresses prandial glucose like exenatide or lixisenatide, or even once a day. You may consider once a week, but that lowers fasting glucose more than postprandial glucose. So I'd probably go with one of the shorter acting ones with that main meal, or prandial insulin. So you weigh the pros and cons of each, discuss with the patient what would be the more appropriate way, what her goals are for body weight, and changing her nutrition a little bit.
Yeah, I think that's probably the way I would go too. I'm always interested in trying to lower someone's weight because I think they feel so much better with less weight, decrease their insulin resistance. But I do think that having a fasting glucose of 110 to 120 means that her postprandial sugars are high, and giving insulin preprandially would necessarily take care of that as well. Of course, I would be also concerned, depending upon how late she eats during the day, of that hypoglycemia that you sometimes can get postprandially with pre-meal insulin, and she would have to obviously change her diet appropriately to make sure that she was evening out her calories throughout the day, as you mentioned. But I think that I agree that the idea of a pre-meal insulin, particularly probably a pre-dinner insulin, might be the most appropriate way to go in this patient. And I think that she would probably get to her A1C goals relatively easily and have less likelihood for the nighttime hypoglycememia, which is very distressing to patients. They hate getting up in the middle of the night feeling, like their bedclothes are soaked. They're feeling very uncomfortable, and it oftentimes makes them very nervous about taking insulin, going forward, which in this lady is something that's probably going to be required for forever.
You might get some pushback from the patient who doesn't want to take another injection. This is a common thing. I take this injection. I really don't want to do another one. You could discuss other options. Glimepiride is could be done twice a day, although I'm not sure you're going to get her A1C down very much, well, just up titrating the glimepiride. You'd probably get a very small incremental benefit, or maybe move it to the evening if that's the time of the main meal. Another option would be an oral prandial agent like acarbose. We don't use it that much in this country. Very popular in some other parts of the world where they have very high carbohydrate loads, and they seem to tolerate the side effects. I use it sometimes in very small doses, and it can be useful. Maybe just at that meal where she's having a lot of carbohydrate and maybe a lot of fat in the evening. But I think some discussion about the spreading the nutrition through the day might be appropriate.